You will now have the opportunity to listen to a number of patients who demonstrate the spectrum of auscultatory findings of a very common heart lesion. It has been estimated that possibly 15 million people in the United States have this condition. We are listening at the apex of a 23-year-old woman. Note that there is a prominent mid-systolic click, which is typical of mitral valve prolapse. The first heart sound is slightly accentuated but normal, as is the second heart sound. Next, we will listen to a series of patients who have mitral valve prolapse and have either a single systolic click or several clicks. Our first patient has a single mid-systolic click, apex. Next, a patient with a mid-systolic click who has an arrhythmia due to premature beats, apex. Our next patient has a single systolic click that occurs in late systole just before the second sound, apex. Another example of a single click in late systole, apex. The next patient has mitral valve prolapse as evidenced by her several clicks heard in mid to late systole, lower left sternal border. Now, listen to this 25-year-old woman who has mitral valve prolapse and represents a 10% group who are symptomatic. She has occasional chest discomfort, not of the coronary type, and palpitation due to premature beats. She had one episode of paroxysmal atrial tachycardia in the past. Her symptoms have been relieved on medication. She has systolic clicks in the last half of systole. Although these clicks are usually present, occasionally they are not detected. Apex. Next, listen to this young secretary with mitral valve prolapse describing her symptoms.
Why don't you describe what bothers you?
What bothers me is the infrequent beating, the irregular beating. And it feels sometimes I could feel like it pulls a little air. I can feel it like in my throat.
In your throat.
Pulling a little air. I can sometimes tell when it's going to happen. When in between like some breathing, I can tell when it's going to be ready to do the click or the funny beat.
That's a premature beat and or skip. And when are you more likely to get it?
when I lay down. And then I have occasionally felt it when I go to the bathroom.
Yeah.
I felt it then, and occasionally I felt it when I get ready to eat.
The bathroom would be bowel movements, but not urination.
No.
Third left sternal border. You could detect her frequent premature ventricular beats and her series of clicks that were heard in the mid to last part of systole. Let's listen again. Our next patient has a single mid-systolic click. Frequent premature beats are present, as they are in a number of patients having mitral valve prolapse. Apex. Our next patient is a 58-year-old lady with prolapse of the mitral valve. She also has the straight back syndrome. She has a single mid-systolic click, and the rhythm is irregular due to frequent premature contractions. Various arrhythmias can be present with mitral valve prolapse. Premature contractions or tachycardias, such as paroxysmal atrial tachycardia, atrial fibrillation, and less commonly, even paroxysmal ventricular tachycardia. Always search carefully to rule out mitral valve prolapse when any of these arrhythmias are detected, particularly in a woman in her teens through middle age. Another clue to suspect the presence of mitral valve prolapse is a patient with some chest anomaly, such as straight back syndrome, pectus excavatum, or asymmetry of the chest rib cage. Possibly 50 to 60% of patients with mitral valve prolapse have an associated chest anomaly. This patient, as you recall, has a typical straight back, in addition to her auscultatory findings of a mid-systolic click and frequent premature nodal contractions. Apex. Our next patient is a 47-year-old lady. We are listening to the apex, and several early to mid-systolic clicks are heard. Systolic clicks, therefore, can be multiple without a systolic murmur, and generally are heard in mid to late systole. Less commonly, they are noted in early systole. She also had a straight back. Note respiratory variation of the systolic clicks. A 40-year-old woman with mitral valve prolapse. We're listening at the apex. She has several mid-systolic clicks. This is a 23-year-old lady who has mitral valve prolapse manifested by the sculptatory findings of multiple rapid successive systolic clicks heard at the apex. The patient that we have just listened to had clicks in mid to late systole. However, an unusual and poorly recognized variant is that they may occur only in the early part of systole. This is an example. Note that these rapid systolic clicks occur in the first half of systole rather than in mid or late systole. This rapid succession of clicks can simulate the flipping of a deck of cards or the creaking of new thick leather. Also, as an interesting variant, they may be better heard at the mid-left sternal border or pulmonic area rather than at the usual location at the apex or lower left sternal border. This woman was about 50 years of age and on two separate occasions and in two different hospitals had been previously diagnosed as having a pericardial friction rub of acute pericarditis. The multiple rapid systolic clicks in the first half of systole obviously caused this confusion. However, the very fact that these clicks are only in systole essentially rules out pericarditis. The friction rub of acute pericarditis has either two or three components, not only one. The three components are related to atrial systole, ventricular systole, and the rub in ventricular diastole at the approximate timing of the third heart sound. If the patient has atrial fibrillation, there is no atrial contraction, and the rub has two components, that of ventricular systole and ventricular diastole. Let's listen to a patient with a three-component friction rub. It typically increases in intensity coincident with inspiration. This patient has an acute myocardial infarction. Lower left sternal border. Now, let's listen again to our patient who has this variant of mitral valve prolapse, pulmonic area. Here's another patient who has a series of rapid multiple systolic clicks in the first half of systole. They are better heard over the pulmonic area as compared with other areas. At the apex, we hear what is more typical of a systolic murmur. Now, listen over the pulmonic area. third left sternal border. Lower left sternal border. Apex. Our next patient is a 30-year-old nurse who had been previously diagnosed as having congenital valvular pulmonic stenosis. However, she too has this variant of mitral valve prolapse. She is asymptomatic. First, we will listen over the third left sternal border. Note mid-systolic murmur with several clicks. She is now squatting. The murmur is in mid and more towards the latter part of systole. Now we'll have her return back to standing. The rate is increasing. Now we hear the multiple rapid systolic clicks in the first half of systole. Remember, this patient's murmur had been confused with that of pulmonic stenosis. For comparison, our next patient has congenital pulmonic stenosis. Right ventricular hypertrophy was present on the electrocardiogram and the X-ray, whereas our patient with mitral valve prolapse had a normal electrocardiogram and cardiac X-ray. Pulmonic area. Sometimes only a systolic murmur is present and no click or clicks are heard. The murmur is usually in late systole and can be crescendo up to the second heart sound, or it can be crescendo decrescendo. At other times, the murmur may be mid-systolic, and occasionally it can be holosystolic with late apical accentuation. Our next patient has a late apical systolic murmur. No click is heard. Note that this murmur is in the latter part of systole. There's a pause between the first heart sound and the beginning of the murmur in mid-systole. It is a lup, lup, lup. No systolic click is present. Frequently, both clicks and a murmur are heard, hence another name, the click-murmur syndrome, which is synonymous with that of mitral valve prolapse. Our next patient is a 22-year-old man. If you listen carefully and specifically, first for a mid-systolic click and then a systolic murmur introduced by the click, both will be heard and were present at the apex and left lower sternal border. He also illustrates the familial aspect of this condition, since his mother and her mother also have mitral valve prolapse. His grandmother is the only member of the family who had any symptoms. They were chest discomfort, palpitations, fatigue, and dizziness. She was treated with propranolol, which relieved these complaints. The great majority of patients having mitral valve prolapse are asymptomatic. This is the patient's grandmother. Note that she has frequent premature beats. She has a click or clicks around mid-systole and a late apical systolic murmur. Now, listen to his mother. She has a mid-systolic click. Occasionally, a couple of clicks are heard. Sometimes she has, in addition, a late apical systolic murmur. Occasionally, no click or murmur are present. Recently, she is bothered by frequent premature beats, for which she has taken medication. Apex. Now, let's listen again to the young man. Apex. At times, the systolic murmur has a musical quality resembling the whoop of a child with whooping cough. Because of this, we termed it the systolic whoop. To some, this murmur resembled that of the honking of a goose and called it the systolic honk. It is generally in late systole and can be loud or faint. Sometimes it is so loud that it can be heard without a stethoscope, enabling others in the room to also hear it. It can go la-bzum, 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 la-bzum. And still at other times it is very faint, and one would hear la-poo, 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 la-poo. And still other times it would be almost like the squeak of a mouse. La-poo, 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 la-poo. Let's listen again to our patient with this late apical musical systolic murmur that is best heard along the lower left sternal border and apex. The rate is faster because she is only 7 years of age. It is typical of a variant of mitral valve prolapse, reminding us that this condition occurs at all ages, including youth and old age. Illustrating mitral valve prolapse in older age is our next patient, who is 66 years of age. Note that there is a gap between the first heart sound and the onset of this murmur, which is in the latter part of systole. It is harsh, but also has some musical qualities. Patients with Marfan's syndrome or a variant of it may have mitral valve prolapse. A spectrum of findings can be heard varying from a systolic click or clicks to a mid or late apical systolic murmur, or clicks in combination with the murmur. Our next patient with Marfan syndrome has a systolic click introducing a late apical systolic murmur. An occasional premature beat is also heard. The auscultatory findings were localized at the apex and poorly heard along the lower left sternal border. Lower left sternal border. Rupture of a chorda tendineae in these patients can result in a dramatic change from the benign auscultatory findings of clicks and/or late apical systolic murmur to a loud holosystolic murmur that decreases in the latter part of systole. 18 years ago, this man had a late apical systolic murmur of mitral valve prolapse. He now has a holosystolic murmur due to a ruptured chorda tendineae, which was the result of infective endocarditis he had 3 years ago. He is scheduled for surgery on his mitral valve tomorrow. Apex. Our next patient is a 65-year-old physician. He has a holosystolic murmur of mitral regurgitation. He was first evaluated about 20 years ago, at which time he had several mid-systolic clicks and a late apical systolic murmur. His findings were typical of mitral valve prolapse. His present diagnosis is moderately severe mitral regurgitation caused by a rupture of a chorda tendineae. Atrial fibrillation is present. He is still able to practice medicine without any difficulty. Apex. Our next patient also has a ruptured chorda tendineae. Apex. The patient we have just listened to has blue sclera and a history of many breaks of his bones. He has osteogenesis imperfecta. As you will recall, osteogenesis imperfecta is a disorder of connective tissue, as is Marfan's syndrome, and can produce similar pathology of the cardiovascular system. He apparently had the sudden onset of this loud systolic murmur that was best heard at the apex. It is holosystolic, but decreases in the latter part of systole. He had chronic cardiac decompensation and died 10 years later. At postmortem, the mitral valve showed changes indicating prolapse of the mitral valve and a ruptured chorda tendineae. This 29-year-old woman previously had no murmur and was entirely asymptomatic. Only a couple of mid-systolic clicks had been heard by her physician. She had mitral valve prolapse. She subsequently had infective endocarditis on her mitral valve, and during medical treatment for this, had the sudden occurrence of acute mitral regurgitation, which was due to a ruptured chorda tendineae. This loud grade 5 holosystolic murmur occurred, which was widely transmitted over the precordium. We are now listening over the pulmonic area. Note the holosystolic murmur, which decreases in the latter part of systole. Also note alternation of the murmur as well as alternation of the second heart sound. Severe heart failure is present. Surgical repair of her mitral valve was necessary, which was successfully performed. Prolapse of the mitral valve can occur in association with other congenital heart defects. For example, it has been estimated that 10 to 20% of patients with atrial septal defect also have mitral valve prolapse. This is exemplified by our next patient, a teenage boy. First, apex. A series of clicks are heard in mid and late systole. The first heart sound is more widely split than usual, the second component of which, the tricuspid, is louder than the first component, the mitral. This louder tricuspid component of the first heart sound may occur with atrial septal defect. Remember, normally the first component, the mitral, is usually the louder. Now, let's listen again. Listening over the pulmonic area, the second sound is split and does not become single with expiration. A faint mid-systolic murmur is also present. Another patient with atrial septal defect and mitral valve prolapse. Note late apical systolic murmur. No systolic click has ever been heard. Apex. Now, let's listen to one more patient having mitral valve prolapse and an atrial septal defect. First, at the apex. Note a grade 3 systolic murmur in the last half of systole. Pulmonic area. Wide splitting of the second heart sound is present. It does not become closely split or single with expiration. A grade 3 mid-systolic murmur is also present. Even though we have just listened to some patients who have a serious complication of mitral valve prolapse, that of mitral regurgitation due to rupture of a chorda tendineae, it is worthy of re-emphasis that the great majority of patients having mitral valve prolapse have an excellent outlook and prognosis and can lead a perfectly normal life. Finally, we will now listen to the master musician James Galway playing his flute. Listen carefully, and you might detect a number of musical systolic clicks.